let's talk EEGs. So EEGs, we're essentially just looking at your brain activity. That's all we're doing. So we're putting electrodes on your brain and we're seeing how those cluster of neurons are firing at that moment. Now, your entire brain is functioning in synchrony. It's working like a beautiful orchestra. And we have the conductor, which maybe we'll call that the reticular activating system of consciousness, is allowing all of this to smoothly move in beautiful flow. So when we put the electrodes on, we put some on the right side and we put some on the left side. We're putting them over the lobes of the brain. And the two things that EEGs help us with are encephalopathy, to see if there's slowing of brain activity, and two is seizures. And within seizures, it's to identify, is there a generalized seizure or a focal seizure? And if there's a specific syndrome that we might see. So the first thing we look at is the actual rhythm of the patient. So this, we've stuck an EEG onto a patient. And so if we talk through it, we've got on the right hand side, everything that is an even number is the right hand, and everything that is an odd number is the left hand side. So for the right hand side, you see there's F, T, so that's frontal, temporal, O is for occipital, C is for central, P is for parietal. And so these leads, each of these leads is telling you which part of the brain we're looking at. Right here in the middle is just straight down the middle, and then we have the same on the left hand side. So each of these blue lines represents a second. And can you see how the brain is working in beautiful synchrony here, as the left and the right are moving in this beautiful rhythm? So we've got these up and down, these waves that are coming through. And what we do to begin with is we just count the waves. 1, 2, 3, 4, 5, 6. Let me put a pointer on. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So there's 11 beats in that little second. So we say that's 11 hertz. And so we can look and say, is this part of the brain at 11 hertz and is this part of the brain at 11 hertz? And if you were to count it, there might be some slight variations, but essentially it would be exactly the same because the brain is working together in perfect and beautiful synchrony. So the first thing we do is we check the hertz. So if you have 9 to 12 hertz, that's normal wakefulness. You're awake, you're doing your thing, you're doing well in life. You take too much benzos, so now you want to go to bed, you pop some benzos, but you actually end up getting beta, so you go to 13 to 15 hertz. You will feel drowsy, but it's this interesting phenomena where you have an increase in the amount of hertz when you have too much benzodiazepines. But let's say you fall asleep, you will drop down to 5 to 8 hertz. So this is what slow brain activity looks like. So if we take the same second, 1, 2, 3, 4, 5, 6 hertz now. So this patient is sleeping, or they're very drowsy. They're at 6 hertz, so we call that theta. So alpha is normal, beta is too much benzos, B is for benzos. Theta is drowsy, you're getting sleepy, and then once you hit 1 to 4 hertz, you're asleep. Your brain is still going at kind of in a synchronous manner, but you can see how there's significant slowing. Even the waves are getting a little wider as well. So we can use this to look for encephalopathy. Now, if you remember, encephalopathy is any sort of dysfunction of the brain. So this could be due to I've taken too much opioids, I've taken too much of my lithium, I've taken whatever it might be, and now I'm in kind of a semi-comatose state. I have taken too much of my sleeping tablet and now I'm in a semi-comatose state. Encephalopathy can also be due to my liver and I've got too much ammonia and so I'm in a drowsy encephalopathic state. It could be due to an infection. I've got HSV encephalitis and now I'm in a drowsy, confused state. And so what you see is slowing. You see slowing of the brain activity. How do you know they're not sleeping? Well, they're in front of me and I'm saying, wake up, Johnny, and they're not waking up and they've got slow brain activity. So they're clearly not asleep. They're in front of you, but they've got slowed brain activity. And this can go from theta down to delta as well. So you can have people who are severely encephalopathic that have just got very slow background activity. So you can see generalized slowing, but you can also see localized or focal slowing. Now, I don't have a perfect image for this, but I want you to imagine that, let's just say the left side of the brain looks like this and the right side of the brain looks like this. that would say there's focal slowing in a region, and that would suggest there's some sort of underlying structural pathology. Now, back in the day when we used to use leeches for medicine and we didn't have MRIs or CT scans, this is what they used to do. They used to put ECGs on patients, not ECGs, EEGs on patients, and they used to say there's structural abnormalities there because there is slowing of the brain. So when someone comes in with a stroke, and if you were to stick EEGs on them, you would see slowing in the region of the stroke. And you can say that part of the brain is just not working as well. So it's very good to look at generalized encephalopathy. It's good to look at focal regions of slowing as well. Now, the next one is to look at epileptic activity itself. So if we look at this patient, you can see the background is really slow, and it's really slow. There's only like 1, 2, maybe 3 or 4 hertz here, at the most 5, is because this patient is asleep. They're asleep, they're having a good sleep, and you can see right here, there is this sudden spike of electrical activity. And can you see how it is all beautifully lined up all the way through? So with it being beautifully lined up all the way through, this is an epileptic this is an epileptogenic activity. This is epileptogenic activity. This is a spike of epileptic activity, and the brain is firing spontaneously. We can see that it is generalized. It is happening, if I was to draw a line, exactly in sync with each other. Maybe there'll be a slight off second, but generally everything is firing at the same time. And then do you notice how there is a slowing of activity that occurs here? Now, what's actually happening is, if you remember the pathophysiology of epilepsy, the pathophysiology of epilepsy is this paroxysmal depolarization shift. What is happening is you have your resting membrane, it depolarizes, there's an overshoot, and then a repolarization, hyperpolarization, and then it stops. And so that's how a nerve or a neuron fires. This is how the heart fires as well. And that's normal. And you have to have this period of, during repolarization, of a refractory period. And that prevents the neuron from firing again. When there is a lack of a refractory period due to a pathology of some sort, then you just get continuous firing. And when enough neurons fire continuously, well, that's what a paroxysmal depolarization shift is. And that's what a seizure is. So when we do an EEG, what we're actually doing here is we're actually seeing this paroxysmal depolarization shift, and then we're seeing some level of a refractory period that's occurring, and hyperpolarization that's occurring here. So this is what we would call spike, and then the slowing is the wave that comes after it. So this is not a seizure, this is just epileptic kind of focus, or a little spike and wave. It's just one little bit of activity. Now, if this were to fire once, and then again, and then again, and then again, that's when you develop a seizure. And so if we were to have a patient in front of us with an EEG on having a seizure, we would see spike and wave, spike and wave, spike and wave. The entire screen would be spike and wave. Now, when we see a seizure, we can use this to actually narrow down what type of seizure it is. And very quickly, you can say this person has a generalized seizure. This person had a generalized seizure. If this continued on, this would be a generalized tonic-clonic seizure, or maybe an absence seizure as well, because those two are generalized seizures. So it helps us in that way. It can also help us figure out the syndrome. Now, there's tons of epilepsy syndromes, and the most common one that you need to know for your exam is your idiopathic generalized epilepsies or your genetic generalized epilepsies. And so same name, they're just interchangeable. And classically, these are the patients with juvenile myoclonic epilepsy, absence epilepsy, normal development, normal intellectual development, and then develop seizures in early childhood or teenage years, usually generalized tonic-clonic seizures, usually absence seizures or myoclonic seizures. And the pattern they have on EEG is they have 3 hertz spike and wave. So they'll have 3 of these spike and waves within a second. So 3 hertz spike and wave. And if you did photic stimulation, and I will demonstrate photic stimulation right now. So what we do is we do photic stimulation. And if you did photic stimulation, they would develop a seizure, and you would see this electrical activity occurring at that stage. So you can use your EEG You can use the EEG to figure out is it generalized, as well as can you narrow down the syndrome. Now, there's other syndromes like Dravet syndromes, etc. These are childhood epilepsies. I don't think you really need to know those specifically for physicians' exams. If you're pediatrics, then maybe yes. These have their own kind of EEG patterns, and one of those are what we say is encephalopathic epilepsies, and so they will be background encephalopathy. There'll be specific patterns. You don't need to know that. Now, the final thing we can look at is focal seizures. So this patient, you can see here, is having these spikes and they're having these slow waves. And here, do you see how there's a synchrony that's happening, but it's only occurring in one hemisphere? So this is a focal seizure that's occurring, and this patient's clearly having multiple seizures. And so this can again happen in syndromes like mesiotemporal sclerosis. This can happen post-stroke. This can happen HSV, where someone's coming in with focal seizures. And this might manifest in a multitude of different ways, including loss of consciousness, focal motor seizures, or psychic seizures as well. So I think that's pretty much all you really need to know about epilepsy. The main things I would probably say is know your rhythms. So know alpha, beta, theta, delta. Know that alpha is normal, 9 to 12. And that if you're getting drowsy or sleepy, then it's 5 to 8 and 1 to 4. And then there's encephalopathy can cause that as well. And then know that seizures, know the phrase spike and wave. And then know that 3 hertz spike and wave is prototypic idiopathic generalized or genetic generalized epilepsies. Okay, fantastic. Any generic tips on making a stellar neuro referral apart from working in Gegenhalten to the conversation? I'm going to be completely honest with you here. I have a very different viewpoint about getting referrals from people compared to what other people say. My basis is if you want a neurologist to see your patient, just have a question, and I really wouldn't worry about anything else. And I think anyone who gets angry at someone else for not doing a referral properly, just relax. Don't worry about it. Like, at the end of the day, it doesn't matter what the person over the phone tells you. You just have to go and see the patient and take a history and do an exam and do it all yourself once again. So I wouldn't worry too much, apart from saying, I've got a patient, we think they're Parkinsonian, we don't know why, they've got rip-roaring Gegenhalten, could you please come and figure out what's going on? I'd be happy with that referral, honestly. We're neurologists, we're here to help. What more is there? And if I asked a hematology colleague of mine, I've got someone that's got some sort of paraprotein, I don't know what's going on, I'm sure they'd come to the rescue as well. Okay, fantastic. Well, it's 9:55. Unless there's any burning questions, I'm happy to end it a little sooner. To Varanya 8107, were you happy with that EEG explanation? Any other questions you wanted to ask from that? Okay, fantastic. I will take that as a no. Varanya has left the conversation. So we will do this once a month. If you haven't already, go to the website basic-neurology.com. Description is in, I should put it in the description actually, now that you mention it. Sign up sign up for the newsletter. So once a month, I'll drop a newsletter, updates in the field, some interesting tips, something that, things that you need to know. Keep you up to date with the course information. Every month we'll do a Q&A. Send in your questions beforehand and I'll try to go over them as well. But once again, I'm more than happy to just do it through the chat as well. And just follow us on social media. And thank you so much. I think I'm happy with the very, very first session of this Q&A. Hopefully we'll get more people and more questions. But thank you so much for joining.